Good morning, everyone. My name is Maya Luria with TMC for Seniors, and I am thrilled we are in Heart Health Month. And today we are going to be talking about cardiovascular disease, fact versus fiction. And I have Dr. Gordon Watson with me here from Pima Heart and Vascular. So welcome, Dr. Watson.
Thank you for inviting me.
I did want to just share a little bit about Dr. Watson's background. He is board certified. He's a board certified cardiology specialist. He graduated from the University of Arizona, and he did his residency in internal medicine and his fellowship in cardiovascular disease. He has over 30 years experience in treating adult congenital heart conditions, cardiac electrical system procedures, and heart disease. He is passionate about all aspects of cardiac echocardiography, valvular heart disease, hypertension, and cholesterol management. So thank you so much for being here, and thank you for sharing all your knowledge today about cardiovascular disease, Dr. Watson.
Thank you. I'll give you about 20 to 25 minutes here of what I would call the bread and butter of cardiology. This is what I probably spend 75 to 80% of my day talking with patients about and dealing with. And what I'm going to try to do is cover in the next 20 to 25 minutes some of the basic causes of coronary artery disease and some new tests that we have available to assess for it, and then discussing some of some risk factor modification strategies. So what I'm going to do is start with just a brief introduction. I work for Pima Heart and Vascular. My office locations are there on the bottom of the screen. I'm mainly in the northwest side of Tucson, Oro Valley, Northwest, Orange Grove, Saddlebrook, and Oracle. You see my website at the bottom, and I'm also you can also find me through the Pima Heart and Vascular website. So what I'm going to try to do here is go through what is the #1 killer by far in the country, despite the issues with the COVID pandemic over the last year, and it's atherosclerosis and coronary artery disease. So briefly, what are the statistics here? About 1/3 of all deaths in the U.S. are related to cardiovascular disease, mainly myocardial infarction and diseases related to coronary artery disease. About 2,300 Americans die each day of cardiovascular disease, which is one about every 38 seconds. If you remember, sort of at the peak of the COVID pandemic, we were around 3,000 deaths a day from the COVID pandemic, and everybody was hearing that in the news. But this is what's happening every day from cardiovascular disease, and we really don't hear that much about it. CV disease claims more lives each year than all forms of cancer and chronic lower respiratory diseases combined. So heart disease, including coronary heart disease, hypertension, and stroke, remain the #1 cause of death in the US. Approximately every 40 seconds, an American will have a heart attack. Between 2013 and 2030, the estimated cost of coronary artery disease treatment is projected to increase by about 100%. So it's a very significant cause of medical issues. Included in that is stroke. Stroke occurs about every 40 seconds in the US. Stroke kills someone about every 3 minutes, 45 seconds in the US. And in 2015, stroke accounted for about 12% of deaths worldwide, making it the second leading cause of death behind heart disease. And these diseases are linked together very strongly. So what I'm going to try to do here over the next 15 or 20 minutes is go through what are the main risk factors for coronary heart disease. It's what we call Life's Simple 7. This is what I talk about with most of my patients every day. It's the somewhat what I would call the boring stuff over time, but it's also the most important things that we have to deal with. It's smoking, which is still a very big cause of cardiovascular death, physical inactivity, which we'll talk about, nutritional status, obesity, cholesterol levels, diabetes, and hypertension. And I'm going to work through each of these for a couple of minutes to point out some pertinent facts related to all of them. So we'll start with tobacco use. Despite less talk about tobacco use and the fact that we all think it's decreasing, which it has decreased to some extent worldwide, including secondhand smoke, is still one of the top 3 risk factors for disease as of 2015. Tobacco use is the largest preventable cause of death in the U.S. Greater than 480,000 Americans die per year due to smoking. In 2015, still about 15% of adults still smoke, which is a relatively high number of people. So what are the issues with smoking? Obviously, it increases your risk for about 2 times higher for heart attack. It increases the risk of stroke 3 times higher. But where I focus when I have somebody who's had a significant smoking history is in peripheral vascular disease. Peripheral vascular disease is basically atherosclerosis or cholesterol buildup in the leg arteries, sometimes in the arm arteries, but more in the arteries in the abdomen and below. And as tobacco use increases the risk for this disease about 5 times over people that do not smoke, as compared to 2 and 3 times for stroke and heart attack. So somebody who's had a significant smoking history, I will always ask about discomfort in the legs and whether or not their pulses, I check their pulses and make sure they're okay. So tobacco makes me really focus on peripheral vascular disease on top of the heart attack issues associated with it. Next is physical inactivity. And I probably mention this in 90% of my visits to my patients, that this is one of the most important activities that somebody can do to prevent coronary artery disease. About 1 in every 3 U.S. adults do not engage in any leisure time physical activity. Unfortunately, there's too many cell phones, smartphones, computers, TVs, and we do a lot of sitting in front of devices a lot during the day, and especially more over the last year, as everybody says, there's the COVID-5 or the COVID-10 or the COVID-15 pound weight gain, and it's clearly gotten worse over the last year. If you look at students in high school, only about 27% of them engage in the recommended 60 minutes of exercise daily. So clearly it starts at a very young age. Then as a consequence of a lack of physical activity, obesity is definitely a pandemic and or an epidemic in the country, and it has been now for many years. If you look at the United States, the prevalence of obesity in adults from 1999 to 2014 increased from 31 to 38%. So that means 4 out of 10 people in this country are obese or overweight. So how do we determine if somebody's obese or overweight? There's a calculation called a body mass index, or BMI. And it's a calculation based on height and weight. And you can see the BMI calculation, if you're underweight, if it's less than 18.5, we don't see that much. Normal is between 18.5 and 24.9. Overweight is 25 to 29.9, and obese is anybody with a BMI over 30. So as an example here on this graph, if you take somebody who is 5 foot 9 inches and 195 pounds, any weight above 195 pounds is in the obese category. And actually that weight for that height is considered significantly overweight, increasing risk. So that gives you an idea of what a quote unquote normal BMI is going to be. And you can find this graph on the internet. And actually, I think we've got copies if you would like to look at this. So how do we calculate a BMI? Well, a BMI is calculated based on your weight in pounds times 703 over your height in inches squared. And it's a pretty easy calculation. So let's move on to cholesterol, which is another risk for heart disease that I spend much of my day dealing with. So about 95 million or 40% of American adults have cholesterol greater than 200, which is considered significantly elevated. 29 million people have a cholesterol greater than 240. And 1 out of 3 American adults have high LDL or bad cholesterol, and 19% of American adults have low HDL or good cholesterol. So that combination makes for a high risk for coronary artery disease. And we're going to talk a little bit about those 2 cholesterols. So HDL is the good cholesterol. It's basically the protein that carries lipids out of the cell wall and the bloodstream back to the liver to be broken down and excreted. LDL is the bad one. That's the one that carries the cholesterol from the liver to the vascular system and causes the cholesterol to deposit plaques in the vascular walls. So this is the one that we focus on because there's really not a whole lot we can do about LDL. So what are the numbers that are considered good? Now, this has really changed. And when I started practicing 20, 25 years ago, what was considered normal versus abnormal has really been adjusted down. So less than 200 is considered desirable for the total, really more or less than 180 now. High is 200 to 239, and very high is over 240. Focusing on the more important part of the cholesterol, the LDL, less than 100 is considered ideal. And actually, in a lot of people with risk factors, actually less than 70 is really considered better. 100 to 129, which used to be considered normal, is now considered above ideal. Then anything above 130 is borderline. Then it goes to 160 to 189, and then above 190 is very high. HDL, which we don't really focus on much, less than 40 is considered high risk for heart disease. 40 to 59 is good, and 60 and above is considered high. High and very good. We don't see that very much. So how does this work? Well, we get our cholesterol about 2/3 out of the liver, which is where it's made, and about 1/3 out of the food we eat. So the liver makes it, goes into the arterial system. You get it from your food. It gets circulated through the liver and out into the arterial stream, where it starts depositing into the plaque, mainly the LDL cholesterol, which is where we focus. So there's the total is considered the HDL plus the LDL plus the triglycerides. We can treat the triglycerides and LDL, but we can't do much with HDL. There's not many drugs, and basically exercise and genetics are a big part of that. Diabetes, another big problem. 9% of American adults have diagnosed diabetes, 3% have undiagnosed diabetes, and 34% of American adults have prediabetes, which we're hearing a lot about now because we know that increases risk. So 1/3 of the population has diabetes. This talk is really not addressed to diabetes. That's a whole talk in and of itself, but being sedentary, too much food intake, being obese, stress, family history of it, and increasing age all increase your risk for having diabetes. So where do we see it being most prevalent? Well, you can see by this graph, red means a very high prevalence, greater than 40%. Anything in pink or red, so south, southeast. But if you look, the whole country is at least 15 to 20% risk of having it or higher. So people with diabetes are twice as likely to develop cardiovascular disease and live 7 to 8 years less than the average population. And it's a huge cost in treatment for diabetics. So what's the problem with excess blood glucose? So excess sugar can't fit in the body cells. It accumulates in the bloodstream and tissues and organs and causes all kinds of problems. There's type 1, which means you don't have enough insulin, and type 2 diabetes, which means that you're insulin resistant or you can't metabolize the blood glucose, which is really the more common problem that we deal with in the older population. And that's the one that's mostly due to lifestyle issues. You can't really help yourself with type 1. That's a genetic problem with not making insulin, but type 2 is a lifestyle issue in a lot of cases. And then if you have high amounts of blood sugar, the excess blood glucose causes blood vessel problems, narrows the blood vessels by helping to deposit fat in the walls of the arteries. And it causes a lot of inflammation, which is also a big problem with coronary artery disease. One of the last issues I want to talk about is hypertension. This is, I think, one of the biggest problems and that we don't focus on enough now. 46% of the US adults have hypertension. That's basically half the country based on the current guidelines. And the important thing to note is what is now considered normal and where the risk increases. So if you look at hypertension, really anything above 120 is considered a risk level of 1, which means you're equivalent to somebody who doesn't have hypertension. Anything above there, starting at 120 millimeters of mercury systolic, doubles your risk of having heart disease. When you move to 130 to 139, also double. Then you move to 140 and above, which used to be considered high normal. You're pushing 2 to 3 times instance of increased risk of heart disease, and then it obviously goes up from there. The point being here is that right now, what we used to consider high end of normal or normal in the 130s is not considered normal anymore because it increases your risk. So here's the newest recommendations over about the last 5 years. Normal is considered less than 120 over 80. Elevated now is 120 to 129 and a diastolic less than 80. High blood pressure stage 1 is now considered 130 and above and 80 to 89 diastolic. 140 now is considered stage 2. And you can see it goes up from there. So now we are treating people in the 130s, which we didn't do 5 to 7 years ago. Why? And the reason is because of the newer data that says anything above 120 is considered increasing your risk. So this is the other question I get. Does age matter for my blood pressure? The answer is absolutely not. You can see here, the blue is 40 to 49, moving upwards to 80 and above. Each increment of higher blood pressure increases your risk of heart disease based on this linear line. And it's the case whether you're 40 or whether you're 70, it's still the risk is still the same. And what we know from big studies over 1 million individuals is that we start seeing the risk of heart disease going up at anything above 115 millimeters of mercury. So what are the consequences? Well, the consequences are this: atherosclerosis. So this is a plaque, a cartoon of plaque buildup in the arteries, starting here, mild, moderate, which it starts building more, and calcification developing, moderate to severe, and you start seeing it narrow the artery till the point when it gets severe and you actually get blood flow diminished. What happens? Well, as these arteries narrow and or the plaque ruptures, you get death of the heart in the form of sudden onset of chest pain and or heart attack. What happens in this situation? Well, you've got the coronary arteries of the heart, the right coronary, the left coronary artery. Plaque is building up in them. This is a blow up of that. The plaque is here, the yellow stuff. What happens is the plaque ruptures and a blood clot forms suddenly. When it forms suddenly, the artery suddenly closes off, and the muscle beyond where the blockage is starts to dive within a matter of minutes. So what do? Well, now we can, this emergency, when somebody shows up in the emergency room, we put a wire up in through the artery, either in the wrist or the leg, run a wire down into the artery, cross over where the blockage is, put a device called a stent, which is a metal scaffolding device, over a balloon, blow up the balloon, and we basically smash the plaque up against the wall. And that saves people's lives, but it doesn't really get rid of the plaque. The other option for very severe diffuse disease is to do coronary artery bypass surgery, which is basically they cut your chest open at the sternum and they sew in pieces of vein from your leg, jump over where the blockage is, and sew it down in. Again, this is a much larger part of the talk, which is a separate issue, but those are basically the two ways other than medication we have to treat the problem. So where do we focus? We focus on blood pressure, blood sugar, cholesterol, and body weight. And as we talked about, blood pressure below 120/80, blood sugar less than 100, cholesterol less than 200, and a lower BMI. So what other options do we have? Because I have a lot of patients coming into me asking, okay, I've got a lot of these risk factors. I'm trying to treat what I can do. I'm exercising. I'm not having any symptoms. What is my risk? And many years ago, I used to do a stress test on these people, and the stress test was normal. And I tell them, okay, your heart's fine and you can go on your way. Then 2 or 3 years later, they would come back and they have had a heart attack or a stent or something. And I'd wonder, okay, why? You told me my heart was fine. Why was there a problem? The problem is that the plaque builds up asymptomatically, even when it won't show up on standard stress tests. So now we have another option to assist us. It's called a coronary calcium score. Costs about $100 to $130. Insurance doesn't cover it. Don't ask me why, but it gives us a lot of information. And I'm going to talk about that briefly now. So what is a coronary calcium CT scan? Basically, what we do is we do a very limited CAT scan of the heart without dye, looking for hardening or calcium buildup in the arteries. And you can see here's the artery without any calcium. Here's a little bit of calcium. Here's moderate amount, and here's severe amount. And the more plaque or calcium buildup you have, the bigger risk you have. And then that's ranked in 0 to greater than 400 or more, between none to severe. So the calcification, which is this white stuff in the cartoon, occurs as the disease starts to progress. And you can see the early disease has no calcification, but then very early on, calcium starts to deposit in there. And this can be measured by the score. And it can be by that CT scan. And you can see it happens before there is a significant amount of narrowing to the artery. So people will not have any symptoms in the early, moderate, and advanced stage a lot of times, even when the narrowing is up to 50% or less. The stress test will be normal. You won't have any symptoms, but it will show up on the coronary calcium scan. So when we do this, then we can say, all right, you have disease that we need to be more aggressive about, even in people that don't have many risk factors or that have a lot of risk factors and don't have any symptoms. So this allows the doc to basically tell you whether or not you have plaque, even if you're trying to control everything, to try to focus on doing better with your risk factors, be more aggressive about treating your risk factors, and hopefully motivate patients to do more for themselves. There is an expert panel which is had set up to decide how we use this score. Basically, you use it in the moderate risk category, where you have which is calculated. You can go to a website, which I'll show you, which you can calculate your 10-year risk. And then based on that, whether your calcium score is 0, mild or moderately elevated, or severely elevated, can give us an idea of what we should be doing to treat this problem. I actually use it in anybody that walks in that really wants to know. Anybody above the age of 20 or 30 that is concerned about this, I have no problem doing this test. It's very low risk, and it can gives people information. So this is the recommendations from the expert panel, which you can find online, but it's I think it's a good test for anybody that is worried about their family history of heart disease and whether or not they need to be treating their mildly elevated cholesterol or be more aggressive about their blood pressure. This is the website that you can go to do the risk calculator and see where you sit in the mild, moderate, and severe risk category. Don't really have time today to go into how they do this, but it's very easy to do online. So what's the most important thing that I stress to people? Regular exercise is probably the most important issue that people can do on a day-to-day basis. It helps with blood pressure. It helps with cholesterol. It improves your cardiovascular fitness. It also will help recognize disease earlier on so that it can be treated. Because if you have the disease with exercise first, you're likely going to show up to a doctor to have it evaluated. If you're getting chest pain when you exert yourself, or increased shortness of breath despite exercise. So what are the recommendations? Well, the recommendations are basically 150 minutes per week or more of moderate intensity activity, 75 per minutes of vigorous activity, or a combination of both. So it requires a somewhat of a dedication to do this. And then they also recommend moderate intensity muscle strengthening exercises, what I call low weight, high repetition, resistance training. But the important thing is that any amount of activity is better than nothing. So getting up and moving around during the day, light intensity activity can give you some benefit and offset the risks of being sedentary. So the bottom line is moving is better than not moving, but the more exercise you do, the less of a risk there is of having a cardiovascular problem. And I stress this to all of my patients pretty much every day when they come into me. Besides the fact that exercise makes you feel better. So this is a question I also get, which I think is important to talk to patients about on a daily basis, because there's a lot of people making a lot of money selling things like coenzyme Q10 and a variety of different vitamins to help you with cardiovascular status and living longer. And really, the bottom line is here, from many studies that have been done over the last few years, is that it's a waste of money to spend on vitamins. Vitamins and supplements, there is really no data that it's going to help the heart or do anything unless you have a true vitamin deficiency that a doctor has measured that you need to be taking a supplement for. Outside of that, and pretty much all of this stuff over the counter, if you notice in the fine print, it says this has not been evaluated by the FDA to treat or help anything. When you see that, it's probably not worth your money. It's only going to make your wallet thinner. It's not going to help your health. So that's sort of a brief overview of cardiovascular disease, what the risk factors are, and some of the sort of newer evaluation and treatment modalities. So I can take a few questions if there are any.
Yeah, thank you so much, Dr. Watson. I actually did have a couple of questions that came in. One was actually somebody who said that they were having the symptoms of a heart attack just yesterday, and they went to be evaluated at the ED, and they've done all the tests. They couldn't find anything. So they're just asking, how often could this happen? Or would there be something else that, that basically, I think they're just questioning because they felt like they were really having the symptoms.
Sure. As a cardiologist, I see patients like this all the time. Yes, if you're having severe chest pain and you don't know what it is, the ER is the place to go, because they can check your EKG quickly. They can check blood enzymes to make sure you're not having a heart attack. And they can tell you that you're basically not dying right in front of them. However, I tell everybody in this situation that if you're still having symptoms, it's always reasonable to see a cardiologist, have them evaluate your risk factors, consider doing a stress test or some other type of imaging study to make sure that you still don't have a problem despite not finding anything in the emergency room. So, and I think that there's a lot of other things that can cause chest pain that can be evaluated that your primary doctor can deal with, but nobody is going to do anything else to evaluate you until likely you've seen a cardiologist to make sure that the symptoms in your chest that you were having are not heart related. So there are that's a whole nother talk in and of itself, but there's a variety of testing that can be done to assess that and give somebody an idea if there's a problem there. So just because the ER visit was normal does not necessarily mean that you don't have heart disease that needs to be treated. So that's how to people.
And sort of related to that, the difference between just having chest pain as opposed to a heart attack, is there anything that would sort of maybe help to differentiate when they should go and get help?
Yes. I mean, if anybody with pressure or tightness in their chest that comes on routinely probably needs an evaluation. However, there is a classic setup of symptoms that I tell people they need to pay attention to. If they're getting pressure, tightness in their chest, into their arms or neck, shortness of breath that comes on when they exert themselves and goes away when they stop exerting themselves. In other words, they're walking to their car, they're walking up a hill, they're lifting groceries in the grocery store, that comes on with that and goes away when they're resting. That is very concerning for heart disease. Heart disease is it's a very simple physiologic problem. If you've got a blockage in your artery and you ask the heart to do more exercise or lifting or exerting yourself, that's when the pain is going to come on, because you're asking the heart to do more and the blood can't get through the blockage. So if you have a symptom that's related to exertion, that is something that really needs to be evaluated very soon, because that's a very concerning symptom.
Okay, great. Yeah, I know it's hard for folks it's confusing,
Right.
when they should get the help and when they, when it's not necessary. So I did put up, I have a couple more questions, but I did just put up your phone number there for an appointment. It's 520-838-3540. And let's just remind everyone, Dr. Watson, you have appointments that you do either virtually or in person, and the locations are on sort of the northwest side of town. We've got the Northwest Orange Grove location, and there's also one in Oro Valley, Saddlebrook, and Oracle.
That is correct. Yeah, I see patients mainly on the northwest side of town, but yes, I have appointments at all of those places. Absolutely.
Excellent. Okay. So I did want to share that. Now I have another question that came in asking if polycystic ovary syndrome or menopause increases your risk of heart disease.
I tell you, polycystic, renal problems in general can increase, and other diseases can increase risk of heart disease. I am not aware specifically of polycystic ovary, but actually menopause, there is definitely a link. Estrogen is considered to be protective, and that's why women a lot of times will get heart disease 5 to 10 years later than men, because estrogen has a protective effect. So, and what we find is that after women go through menopause, their risk of heart disease goes up relatively quickly after menopause. So the answer is yes. Menopause, women having disease before menopause, they usually have a very strong family history, or they have other significant risk factors that have not been treated. So yes.
Great. And we will be talking about women and heart disease specifically on Monday for anyone who may be interested as well. So that'll be, that just happened to fit in and didn't know.
Exactly.
And are there any specific steps or something that we should watch out for with the family history of heart disease?
Absolutely. I tell people with a family history of heart disease, meaning if you have male relatives, usually less than 50, 55 or so, that have had heart disease at an early age, coronary artery disease, or females actually below 60 to 65, I recommend much closer evaluation of risk factors. And again, that would be somebody that if they come in with a strong family history, brothers, sisters, mother, father that have had heart disease, I have a low threshold to order one of those coronary calcium CT scans on, because most people want to know what the risk is. And even if they only have a borderline high cholesterol or sometimes even a normal cholesterol, I will actually treat them early on to try to prevent a problem later on in life. Family history is a huge risk factor. And so people with family histories really need to think about getting evaluated, I feel, yes.
Excellent. And then what if somebody actually has a normal BP, cholesterol, BMI, blood sugar, but could they still have heart problems?
The answer is yes. Those are risk factors, but you still got to realize that the number one cause of death in this country is coronary artery disease and heart attack. So you can have quote unquote normal everything, and still statistically, the number one cause of death for that person is going to be coronary artery disease. So, and the other thing I found after treating this now for 25 to 30 years is that every time they come out with the recommendations for what is considered to be normal, the numbers have dropped. So in reality, probably what we consider normal in this country for a lot of the risk factors are really still too high. And so it all depends on, a lot of it depends on family history, and you can still develop plaque even if your numbers are quote unquote normal. That's the scary part about this disease, is that it can still kill you even if quote unquote you've been an exerciser and had normal numbers your whole life. So you have to pay attention to symptoms.
Wow. Okay. Excellent. That was fabulous. That is all the questions that I had come in today. I want to thank you all for being here. Thank you, Dr. Watson. That was a boatload of information for us to sort of go through. And I know it's, learning what those signs are is truly important, and also what we can do to help with heart disease is also very important. Sounds like exercise is definitely number one on the list.
Exercise and watch what you eat. Those are the important things. Thanks for having me.
Great. Thank you so much. We will see you all next week. We have several presentations for Heart Month starting on Monday at 2 p.m. We will be with Dr. Wagner and Susan Smith, who is a Women Heart Champion, and they will be discussing women and heart disease. Thank you again, Dr. Watson.
You're welcome.